Good day everyone, my name is Lars Andriel Argata, student of Master of Hospital Administration program in University of Muhammadiyah Yogyakarta. In this presentation, I will discuss an actual hospital service issue related to the emergency room service at St. Dominic Medical Center in the Philippines. The focus is not only the news itself, but also how hospital leaders should make strategic managerial decisions to improve emergency care access, quality, and sustainability. The issue selected is the announcement that emergency care is becoming more accessible through the PhilHealth Outpatient Emergency Care Benefit Package. From a management perspective, this is a strategic issue. More financial coverage can increase access, but it may also increase patient demand in the emergency room. Therefore, the hospital must be ready in three important areas: patient flow, claim readiness, and inclusive access for all patients. The emergency room is the front door of the hospital. It is where patients and families often form their first impression of hospital quality. If the ER is low, crowded, or confusing, patient safety and public trust may decline. At the same time, if claims and documentation are not managed well, the hospital may face financial leakage. So the key strategic question is, how can the hospital expand emergency access without creating unsafe crowding, poor patient experience, or revenue loss? The main problem is not only about patient coverage. The bigger challenge is patient flow. Using the input, throughput, output framework, the hospital must manage who comes to the ER, what happens during treatment, and where patients go after emergency care. Possible root causes include unclear patient classification, long waiting time, limited coordination between triage, diagnostics, pharmacy, billing, and bed management. This means the hospital needs a stronger operational system, not only a payment policy. If this issue is not managed properly, it can affect four major areas. First, patient safety may be affected because delayed assessment can lead to missed deterioration. Second, patient experience may decline because of long waiting times and unclear payment information. Third, staff may experience higher workload and burnout. Fourth, the hospital may face claim denials, revenue loss, and reputational damage. Therefore, ER improvement is not only a clinical issue but also a strategic management priority. The first strategic decision is to build an inclusive emergency access model. The first hospital should separate triage lanes for critical cases, urgent cases, fast-track cases, and referral cases. It should also provide an ER navigation desk to help patients understand PhilHealth eligibility, HMO coverage, and social service support. Inclusive facilities are also important, such as wheelchair-friendly access, senior-friendly waiting areas, and clear signages. The managerial aim is simple. Access must be fair, safe, and transparent. The second strategic decision is to develop a value-added emergency service line. The ER should not function only as a crowded entry point. It should become an emergency care ecosystem. This can include a fast-track service for minor cases, an observation unit for patients who need short monitoring, and a post-ER link to outpatient care, diagnostics, pharmacy, rehabilitation, and chronic care services. This strategy can improve service speed, optimize bed use, and create better continuity of care. The third strategic decision is to invest in smart ER infrastructure and technology. The hospital should develop a digital command center that monitors real-time cues, triage categories, bed status, and diagnostic turnaround time. Electronic triage and standardized documentation are also needed to support claim accuracy. SMS or QR-based updates can help reduce family anxiety and crowding at information counters. In short, the ER must become a visible, measurable, and coordinated system. The implementation can be divided into 3 phases. In the first 30 days, the hospital should stabilize the system by mapping ER flow, creating triage scripts, assigning an emergency care benefit navigator, and collecting baseline KPIs. From day 31 to day 90, the hospital can pilot the fast-track service, trial observation beds, launch the first dashboard, and conduct weekly management huddles. In the next 3 to 12 months, the hospital can scale the program through ER redesign, integrated referral systems, data-driven staffing, and quality improvement audits. So for me, the hardest decision as hospital leader is enforcing strict triage and redirecting non-emergency cases when necessary. This is difficult because patients often expect immediate service when they arrive at the emergency room. However, fairness in the ER does not mean first come, first serve. Fairness means prioritizing clinical urgency while still giving every patient respectful guidance and an alternative care pathway. My leadership stance is compassionate access, disciplined patient flow, and accountable sustainability. Alright, so I think that would be all. Thank you so much for listening.